So then the next speaker is not, as announced, Dr. Esther Kruidwagen, as her plane was delayed, but Professor Ros Quinlivan, who will speak about the Adult DMD Clinic at the University College in London. Thank you so much, Professor Quinlivan. The floor is yours.
Thank you very much. Can I just check that you can see my slides okay and that you can hear me?
Yes, we can see and hear you. Thank you.
Lovely. Thanks so much, Elizabeth. Thank you for inviting me back today. It's been a really, really good meeting. So I'm going to talk about the service that we run at the National Hospital for Neurology and Neurosurgery, which is part of University College Hospitals. So my background is actually pediatric, but I'm now working in an adult service, purely adult. And I've been working with both adults and children with Duchenne since the early 1990s. These are my disclosures. And as you've heard from the other speakers, we have these growing cohorts now of adult men with Duchenne because the survival is so much greater than it has ever been. And so the clinic that I run here at we call it Queen Square for short, started in 2010. So here's the first bit of data we had in 2011. There were only 20 patients. Now, this is 2021. Now, 2022, we have about 160 adults with Duchenne. And you can see very few of our patients have died during this time. So very marked improvement in survival. Just over half of our patients are either steroid naive, that means they've never had steroids, or they had steroids for a short period in childhood. And the vast majority of these patients use non-invasive ventilation. Just under half of our patients are still on daily or intermittent steroids. As I said yesterday, if these have been started in childhood, we do not stop them in adulthood, we just keep going. And of this cohort, about 9% are still able to walk at the time they transition, which is around the age of 17 from the pediatric service. And another 2% of patients can propel their own wheelchair with the hands and do their own transfers. So it's a very, very different population to our non-steroid users. You heard from Ma about medications that are now available to restore dystrophin. In the UK, ataluren is available only for boys with Duchenne who are still able to walk. And as you can see, we have one patient attending our service who is still taking this medication. And in terms of exon skipping drugs, unfortunately, the UK hasn't approved these for use, but we have 4 patients, adult patients, who are on compassionate use of eteplirsen, which is an exon skipping drug. So what about our service? Well, we do a joint transition clinic once a month with the paediatric team at Great Ormond Street Hospital. Although it's a separate hospital from ours, it's actually physically joined to our hospital. So we have a very, very close relationship with the paediatric team. Within my service, so all of our Duchenne patients are seen in our young adult neuromuscular service. There are 3 consultants and an associate specialist. This is equivalent to a consultant working in the team. And 2 of us have pediatric backgrounds and the other 2 are pure adult neurologists. We have a clinical nurse specialist working particularly with our Duchenne patients. And we hold about 7 clinics per month. And just like all the other centres, during COVID, we learned finally to do telephone and then subsequently video consultations. And these have proved very popular with our patients, but we're also now going back to some face-to-face follow-up appointments. So we now do a mixture of video and face-to-face. We have within our hospital separate specialist outpatient clinics for physiotherapy, orthotics, occupational therapy, speech and language therapy, and dietetics, and clinical psychology. So all of the therapies as outpatients. So our hospital trust is a big trust. So University College Hospital is about a mile away from us. It's our sister hospital, so it's part of the same organization. And we utilize 2 consultants in ventilation who are based at that trust. We also have full-time respiratory physiologist who's part of a big team of physiologists who do respiratory function testing. We have a respiratory physiotherapist just for our service and a ventilation nurse just for our service, and they're based on our site. And our trust did have a huge cardiology department. And about 5 years ago, believe it or not, they sold it to St. Bart's Hospital. So now all of our cardiologists are based at St. Bart's Hospital, which is about 3 miles away from us. So of course, our service is right bang in central London, which isn't the most accessible place. And in addition, when I started here, I realized that most of our patients were having a minimum of between 4 and 6 outpatient visits a year, including on top of that, an overnight sleep study. So it seemed to me that this was a bit crazy, given the difficulties with traveling into central London, and all of our patients were finding it very tiring, and they often didn't attend appointments. So it seemed to me sensible to try and rationalize as many assessments as we could around the annual sleep study. So at our site, we found a location, which was basically a number of offices behind the outpatient department. We applied to the UCLH charity and the Queen Square charity for a capital grant of 1.2 million. And our trust also approved a 1.2 million revenue business case to develop an inpatient facility at the National Hospital for Neurology, where we could undertake our own sleep studies and cardiac investigations. And the design of the ward was, we utilized a number of patients and their carers in the design, so they supported us in designing it. So this is a 6-bedded facility, purpose-built with ceiling track hoist, adapted bathroom facilities and wet room. As you can see, it's an open ward with 1 ensuite cubicle, but it was a safe and accessible environment for people with neurological disabilities due to muscle diseases. So we call it the NMCCC for short, or the Neuromuscular Complex Care Centre. And the goal of our centre is to provide holistic but proactive, so preemptive care for people with neuromuscular diseases. So if you like, I see it as an inpatient facility providing outpatient services. And actually, the service we provide is very streamlined. It is cost effective, and I think the quality is high. And we also allow all patients and carers to stay with the patient if they want to overnight, or if the patient wants them to overnight. So this is our team. And as I say, we've been open now for coming up to 8 years. Dr. Lakshmi is our associate specialist, so she's equivalent to a consultant, and I have to say she's amazing. She knows all of our patients inside out, and they all know her very well indeed. She has very good relations with the patients that come in. She organizes and coordinates all of the investigations, and quite often our patients will email her or ring her with queries. This is Maria, who's our clinical nurse specialist, who supports patients with letters for social services, for disability allowances. So she's kind of the bridge with the community for our patients. So admitting people onto a small ward like this requires really a lot of coordination, because most people initially, we planned for people to just stay 1 night, but our patients told us that they found that too tiring and they needed a break between all the investigations. So on average, people stay 2 nights, some people stay 1 night, some people stay 3 nights. and it depends on how far they're traveling from. So we have an admission coordinator who tries to pull it all together and maps out the admissions for the week. When the patient comes in, they see a neurologist, so it's myself, a cardiologist, a respiratory physician. So both of the respiratory physicians now work on our site. We have a gastroenterologist who you will have met yesterday, Professor Emmanuel. We have a consultant in palliative care who's embedded in the service. And we have an anaesthetist, an ITU and neuroanaesthetist also embedded within the service. We have a clinical psychologist in the service, and we have all of the therapists. So speech and language therapist, you will have met Jody yesterday, a respiratory physiotherapist, and you met Charlotte, our respiratory physio yesterday, an occupational therapist, a dietitian, and of course, we have a nursing team of about 20 nurses, and this is our ventilation clinical nurse specialist here. Over the years, we've built up a lot of experience in looking after men with Duchenne, and we've developed very close links with endocrinology. One of the things we can't do on site is the bone monitoring for people who are on steroids. So that monitoring is either done at our sister hospital, which is UCH, or we refer to Professor Richard Keane, who's a real expert in Duchenne bones and based at the National Hospital for Orthopedics in Istanbul. We also have very close links with our chronic pain team, and they will come and see patients if we have people suffering with really significant pain. And they've helped a lot with a number of our Duchenne adults. We can also link in and have done with our urology service. So this team helps with patients who have bladder issues, and they've been very helpful for a number of our Duchenne patients. We can get our patients seen by ophthalmology when they're in, so if there are any concerns about vision. We don't have a renal specialist on site, but we've developed very close links with a renal specialist who's developed an interest in Duchenne. As I mentioned yesterday, we've seen a number of people who've developed acute renal failure, and he's been really helpful in turning it around and improving their care. So this is our model of care. So we put the patient at the center. They can see all of the specialists that I've mentioned, but we have very close links with the pediatric team for transition from Great Ormond Street Hospital. We also link very closely with community teams, particularly the community therapy teams, and also with our palliative care physician. We'll link with community palliative care services when that's appropriate. We also link with GPs, and we have invited GPs to meetings, multidisciplinary meetings, and we've had a lot of support from a number of GPs. We have close links with patients at home. So our patients have now been on the ward multiple times, so they know the team, and so they can ring the ward if they've got concerns during the daytime hours, to speak with a member of the nursing team or medical team, and they do ring quite often. And finally, we do our best to link with the district general hospitals if our patients are admitted acutely. And that's depending on hopefully the local hospital contacting us, but if they don't, quite often the family will contact us and we'll liaise with that local hospital to try and improve care. So as I said, the admission is quite complicated because what we don't want is people coming into our ward if they have an active infection. So our ward nurses do a telephone consultation prior to the admission to make sure no one has an acute infection. And of course, we have very strict policy at the moment to reduce the spread of COVID. So all of our patients have to isolate for 7 days before they come in and do a PCR COVID swab prior to coming in. So that's the service. I'm going to start first with the disadvantages. So overall, the cost of care is less than going to lots and lots of different outpatient clinics. But each admission is quite costly. And as you can see, we have only got 6 beds. So each admission has to be very carefully coordinated so that we can fill those beds to the maximum. And this can be a problem if we have a patient who, for example, has an unexpected problem. So somebody has a sleep study and we weren't expecting it to be abnormal. And normally we would bring them back in a few weeks, but sometimes occasionally they need to start ventilation sooner rather than later, and they may need to stay in longer than planned. And that means we may have to cancel someone at the last minute. But more of a problem actually is patients cancelling at the last minute. Because these beds are very expensive, it's too short notice to fill the bed. So unfortunately, that means my manager tends to shout at me quite a lot. But on the whole, it works well. The other problem is that as you can see, our growing numbers of patients mean we need a bigger ward. So currently, we're not in the beautiful facility that I showed you, but we're in a temporary facility while a new bigger ward is being built. And this will be a 9-bedded unit, but this time we're building in more cubicles. So if you like, separate rooms and a smaller bay. So it'll be more private for patients. But there are a huge number of advantages, and I think they outweigh the disadvantages. As you've probably realized, the team get to know the patients, particularly those with Duchenne, who are our biggest cohort that come in, very well. And the patients with Duchenne know our team very well. And that's really important for reassuring patients and making them feel comfortable, and also means that they can open up and tell us if they've got concerns. The other advantage is that the team knows each other very well. So every Monday, we have a big multidisciplinary meeting where the whole team meet to discuss the patients that are coming in for the week. And we also discuss the patients that went home last week. So there really is very, very good communication between the team. The team has been working with Duchenne patients now for over 8 years and has become very experienced in their management. And the other advantage is that our patients can access all of the services they need in one visit. And as I've already mentioned, if they've got concerns when the ward is open, they can ring the ward for advice. So we don't recommend they do this if they're acutely ill, but quite often people have minor worries or minor concerns, or they want new bits of equipment, and they can just phone the ward. The other advantage, as I mentioned yesterday in our consensus standard of care document, is general anesthesia. For men with Duchenne, having an anesthetic is really quite problematic. And people need anesthetics for all sorts of reasons, sometimes for reasons that you wouldn't have expected, might be not related to their Duchenne dystrophy. So for example, we have a patient at the moment who needs to have some gallstones removed. Or we've had patients who need bladder stones treated or kidney stones treated, for example. And most importantly, and more commonly, the insertion of gastrostomy tubes. So any surgical procedure, including a gastrostomy tube, is done at our sister hospital, University College Hospital. As I mentioned, we have a neuroanesthetist who's a member of our team. He actively anesthetizes people, and he assesses every single one of our patients before they have any surgical procedure. He then liaises with the anesthetist who's based at University College Hospital. And at University College Hospital, we now have one anaesthetist who does all of our Duchenne patients. Her name is Dr. Mira. And all I can say is she's utterly amazing. There is no patient that she's not been able to anesthetize. Before any anesthetic, the whole team is involved in a multidisciplinary meeting to discuss the pros and the cons and what special management may be needed for the patient. And all of our patients spend a night on either ITU or HDU after any procedure. And I'm touching wood here because to date, we've not had any problems actually with general anesthetics in our Duchenne cohort. We did an audit of our patients coming into the NMCCC. And for those patients who'd been in on more than one occasion, we noted a 60% drop in acute hospital admissions. So this was really important. So in other words, we're trying to keep people healthy in between their appointments. And 91% of patients reported that this kind of model of care was better than they had received before. And also, they all said that the number of services that they could access had been greatly improved. So these people weren't accessing a lot of these services before this unit opened. We also, as I've said, have a clinical psychologist embedded in the team. And in terms of the transition pathway, as you heard from Ma earlier, transition begins in the pediatric service, but it continues in the adult service up to the age of 25. And one of the most important aspects, I feel, of our transition service is to provide peer support. And we have a young person support group. And since COVID, this has gone to Zoom, and it is really very successful. Prior to COVID, actually, they used to meet once a month face-to-face. And that first hour, it was a whole afternoon meeting. It was just a chat and a catch-up. But then the second hour was practical, and they would go to a coffee shop or a restaurant. And here's a group of young people attending 2 different restaurants without their parents, which for many of these young people, particularly those aged 17 and 18, was the first time that they'd gone out on their own. And now some of our graduates from our young person group are being mentored and trained to lead other groups. So this has been really good in boosting self-confidence. I know people have talked about outcomes, and actually one of the outcomes that I've looked at is why those small number of patients we have who died have died. And a number of them were due to cardiorespiratory involvement, cardiac involvement in about half, but also in another half respiratory failure. And I could not understand why this was happening. And when I looked closely at our data, what I found was that amongst these people who died early, there was an overrepresentation of people with learning difficulties, anxiety, and autism or autistic traits. And I think that's partly because they find it really difficult to deal with the home ventilation. And I'm really pleased that we've just been awarded a grant from Duchenne UK for 3 years to fund a clinical psychologist who will look after only our Duchenne cohort, and 1 session a week of a psychiatrist. And the plan is that we will assess all of our Duchenne adults, firstly to make sure that they're able to make decisions, they have capacity to do this. And if they don't, we can put in place an advocate to support them. We're going to assess cognitive function. We're going to look for evidence of autism and autistic spectrum traits. And of course, the other features that are now becoming clear in the pediatric age group are ADHD, anxiety and depression, and obsessive compulsive disorder. And if we find this, we know that these will be the patients we've got to put more care, more, if you like, more input when we're starting new treatments to help them to be able to comply with these treatments. And if necessary, we may need to use medication, particularly for people who have anxiety and depression that's getting in the way of them being able to use BiPAP, for example. So just to summarize, the service that we offer, our goal, as all the other services you've heard today, is to be multidisciplinary and holistic. The difference with our service is it's got to be so carefully coordinated, so we have to have a full-time coordinator. But the advantage is we have very good communication between the teams, between our patients, and we have both a psychologist and palliative care physician embedded within the service. I think the other advantage is we have a dedicated anaesthetist embedded in the service for assessing patients, but also we have a dedicated anaesthetist to actually give the anesthetic for any patient who needs surgery. And she has developed such skill. I think it's been fantastic. We try and see everyone twice a year. It doesn't always work out because we're a busy service, but certainly we try to ensure that everyone comes into the NMCCC at least on an annual basis. And now that we're able to do video clinics, I think it's going to be easier to see people once a year in a video clinic and then face-to-face on the NMCCC. So I think that's probably where we're going to be going in the future. And just to finish, to say thank you certainly to our charity for funding this project and allowing us to get it off the ground, and to Duchenne UK and Muscular Dystrophy UK, who have also really been huge advocates and for their funding support. Thank you very much.